welcome everyone. Thank you for joining. I hope that you find this presentation very informative and something that you can use back home. I know everybody's doing a lot of really good work and things are extremely busy. So I'm really excited today to highlight one region and system in particular that I'm pretty proud of. Today, we're going to be joined by Jennifer Carr, VP of Trauma Services for the Christus-Spawn region, which is in Corpus Christi. Got Randy Inslee from Halo Flight, Chief Medical Officer and Flight Nurse, and then myself, Corey Ricketson. So we'll get into a little bit further introductions here. I am Vice President for Strategic Accounts within Pulsara. I've been here almost 4 years now. My upbringing was in healthcare, was as a paramedic for Austin Travis County EMS, both on the ground and the air side. I was also on our statewide disaster committee. Jennifer Carr, who is VP of Trauma Services. But Jennifer, I'd like for you to introduce yourself and give a little bit of your background.
Sure. Hi. I have been a registered nurse for 20 years. My background, emergency, pediatric trauma, nurse leader, and I currently now, like Corey said, work for Christus-Spawn in Corpus Christi, Texas, as a vice president of our trauma services. We have 1 level 2 trauma center and 4 level 4 trauma centers. I'm very involved at the state level with the regional advisory councils, with Stop the Bleed, with Texas Trauma Coordinators Forum, Society of Trauma Nurses.
Good afternoon. I'm Randy Inslee, and I have 26 years of nursing experience. It goes all the way from ER to ICU, neurosurgical ICU, trauma center ER. Been flying now consecutively with all that for 24. This is my 24th year flying. As the chief flight nurse, chief medical officer, about 75% of my duties are administrative, but I do fly once a week just to keep my foot out there and keep my skills up. Halo Flight is a nonprofit organization, one of the few left in Texas, only one of 2. And we have 6 helicopters, 3 bases, and love serving our coastal bend area in Texas here.
Awesome. Thank you, Randy. So just so that everybody has a little bit of a lay of the land, in Texas specifically, we have regions. They largely follow the same geographic area as our hospital preparedness regions. We call them RACs. They're just regional advisory councils. And their primary purpose was to really streamline trauma care within a region. However, they do have a vast responsibility and oversight from all systems of care, things like PPE, just any number of different initiatives fall underneath the RAC. So the Coastal Bend RAC specifically is down in southeast Texas. You can see they cover a large swath of the Gulf of Mexico shoreline as well. And in here, you do have some urban areas like Corpus Christi proper, but there is a lot of rural area in southeast Texas with a lot of farmland and ranch land and things like that. So we're going to talk a little bit today about how this region came together and tried to tackle a number of different initiatives, but we're going to specifically talk about how they tackled trauma systems of care within that region. So, Jennifer, in looking at this, I'm sure that your problems are not unique for you. So I think the audience would appreciate just kind of knowing at a macro level, what are some of the big issues that as a region you guys decided you wanted to tackle and why?
So as a region, we really needed to ensure when we had patients that were coming to any of the emergency departments that there was continuity of care, that information was communicated clearly to the team from the pre-hospital. And if the patient was then transferred to a tertiary center, that information was communicated clearly. Nothing fell through the cracks, important information. So we just wanted to make sure that we had any issues in communication reduced, make sure we get our patients through the system faster.
So just so that the audience knows a little bit about Pulsara, because we are going to talk in the next slides extensively about some workflow and how we've been able to problem solve here. So I want the audience to just understand a little bit about what Pulsara is if you don't have any idea. And really why we exist is probably the most important thing. So this particular diagram shows moving a patient through a typical system of care. And it doesn't matter if that's a trauma patient, a STEMI patient, stroke patient, does not matter. If we start all the way to the left here, where maybe a first responder gets notified via 911 and they show up to start taking care of a patient, they're jotting down vital signs and doing assessment information. Maybe even they take an EKG or things like that. And then when the ambulance shows up, they give a verbal handoff. I call it the what you got syndrome. So ambulance gets there and says, what you got? And so the first responder gives them a verbal handoff of that information. And it's incumbent upon somebody like Randy to try to remember that information, digest it at the same time that they're assessing themselves and formulating a treatment plan. And then if they call over a radio to a hospital, there's somebody on the other end of that hospital that's listening to that radio report and trying to jot things down. And we all know how that goes sometimes when it's chaotic. Did I miss something? Did I misinterpret something and write down the wrong thing? And then if that hospital says, wow, this patient's a little bit critical, we need more team members, some semblance of this process is probably what you go through, where you call a PBX operator, you say, I've got this patient that's critical. They start looking at call lists, sending out pages or phone calls that are kind of one-way communication. If the patient needs to move to a tertiary care center, that's probably a phone call to a transfer center where you're, again, telling the story, and somebody on the other end is jotting that information down. And then they're calling specialists in order to get acceptance for the transfer and then brokering transport from one facility to another. And it just turns out probably that ambulance or helicopter that's taking them to the second hospital is not the same one that took them to the first hospital. So we see a lot of opportunity, not only for red tape that causes slowdowns in the movement of that patient, but also critical communications loss and breakdowns as well. So what Pulsara does essentially is we create a communications channel for a dedicated patient. Think of it kind of like group chat. If we were going to coordinate a dinner tonight with 5 of our friends, we would probably start a group chat. And then if Jennifer wanted to add someone to that group chat, she would just add somebody. And if I was going to be late to the dinner, I may say, Jennifer, could you just post a picture real quick of the menu so that I could look at that and tell you what I want to order? Pulsara is no different. We allow a patient channel to be created for a specific patient event, and it's all secure and encrypted. So it's something that normally we step into a healthcare environment and we're back to faxes and phones and radios and antiquated technology because of HIPAA reasons. With Pulsara, it's completely encrypted and secure, and we can communicate in ways that we normally communicate in everyday life, like group chat. We can upload images. We can do live video even, so that we can put eyes on patients and those could be recorded, et cetera. The key is that we put everyone into a unified patient channel, and that patient channel can expand as the patient moves through the system. So if we take that same diagram, maybe that first responder starts the patient channel and puts in a little bit of information, maybe some demographic information, maybe they take a picture of an injury. And so when that ambulance arrives, they simply add them to the same channel. And then they could start to build teams if they need to. Let's say I need a medical director to remote in with me and look at the patient really quick for some orders. Completely feasible within Pulsara. But instead of calling over a radio to that hospital, they send the alert through Pulsara, which allows the hospital to take immediate action and add other team members if needed. I need a trauma surgeon. I need x-ray, things like that. Instead of that phone call going to a transfer center, it could actually be pulled in directly through Pulsara so that they have all of the information that they need in order to start that transfer process. And then let's just say it's Halo Flight that gets added into the channel for that transport. The great thing is we are all in that channel. And if Randy comes in later in the game, he can catch himself up on everything that happened from the initial patient contact with that first responder. So just to give you a quick example of creating a patient channel, this is going to be a simple trauma case. It's not going to last long. I just want to show you what the user interface looks like before we go through the next slides. So I'll talk through this as we're going through. I'm just starting a new case. We do have things like driver's license scanning. We can scan a lot of the different things within Pulsara, but that dumps the demographics of that patient already into that channel. I can take pictures of injuries. This does not store to my camera roll. It's all HIPAA compliant, so it's in the cloud. I'm choosing a trauma patient here that we're going to be treating, And then I may even do talk to text in order to give a chief complaint. This is not dissimilar to a radio report today. It just puts this into text now so that anybody on the other end can read that and consume that information quickly. And then I simply select a destination. It does auto-calculate ETAs and things like that. Okay, so now that we have a little bit better understanding of what Pulsara is, then, Randy, I've been a flight medic as well, and so I share in some of the frustrations, but it'd be nice for the audience to know, if they've never been on an air ambulance crew, what some of the challenges are when we go in, we fly in, and we're going to be taking over patient care from somebody. What are some of the things that we run into out there?
Well, number one is communication is always the issue. The channels that you communicate with your EMSs, sometimes they're great, sometimes they're not. There's the old joke about gremlins, and you worked fine yesterday, why not today? And or there's just mechanical failure. So sometimes you don't get all the information that you would like to get. So it's been nice to be able to start getting that information. Even as we're taking off, we're already getting alerts from the EMS, and they're showing us pictures of the car or pictures of the scene. So the frustration is almost always communication, and Pulsara has definitely helped get around some of that.
Yep. So I remember, landing and maybe grabbing a patient quickly. And then as soon as I'm in flight, I'm thinking to myself, wow, I wish I would have asked this question, or how much vecuronium did they give this patient? Did they give vecuronium? And now I have to ask my dispatch, what was the crew that was on the ground? How do I contact them when I get to the trauma center? So a lot of that stuff I feel like is alleviated with this. And we're going to go through a case in a few minutes so people can kind of see a real world example of that.
Yeah, they might have cleared that channel, and now you have to go back and find them. With Pulsara, you just shoot them a text and they get it. They get it even though they're done with that call.
Right. So Jennifer, I know, Texas had actually adopted largely Pulsara, and it was under state contract. So maybe you didn't have some of the regional challenges to adopt this that others across the United States have. But what was the process at the RAC level for saying, you know what, we could use Pulsara and let's go forward as a region?
We had to make a decision as a RAC to, even though we didn't have all the answers and we knew it wasn't hardwired, to just do it. This was something that we really wanted to try out because there was especially since it was supported by Texas, and we wanted all of our EMS in our region to be able to send the report to the ERs on any type of patient that they were bringing in, trauma, non-trauma, it didn't matter. And so we just wanted to work and get all of the EMS within our 12 counties to start doing this. And that definitely took time and education and continued education and bringing in, Corey to teach them some of the tips and tricks. But we really we knew that there is resistance to change sometimes, especially with people, because this is the way we've always done it. And especially when the change is technology. And so we just really had to continue pushing forward and trying this, because we know some of the disadvantages of a radio report is that the quality is not always good. Sometimes you miss how much vecuronium was given. You miss that communication. Also, because sometimes in some of the emergency rooms that I've been in, emergency departments, is that everybody can hear that radio report, not just the people that need it. Sometimes people are hearing it that really shouldn't be hearing it. And so this was a more secure way to get good information communicated to the team timely. And we could, like Corey has mentioned, send pictures, lots of real concrete information that we could get on these patients.
So Jennifer, I forgot to mention, I'm also on the RAC board, but Jennifer, remember one of the things that really drew us to this was we've been dealing with how do we get our 12 leads to the hospitals? A lot of the larger services could afford the brand new monitors that transmit. Most of the rules could not, and so this was a fix for that too. Getting those 12 leads where it can be sent securely straight to that physician to activate a cardiac alert. So that was a big drawing force for us as well.
Yeah, we took it in steps of basically your crawl. walk then run. Corey likes to say that. And, we just had to take it in baby steps. And especially with hospital leadership, we really had to, show them that this was secure. This was, moving forward with technology and the benefits that we would receive in better patient care with this.
Yep, that's perfect. And I remember being in some of those rooms when the Coastal Bend RAC decided to just vote and go forward with this. There's always going to be some naysayers and some folks that aren't as apt to take the technology in. And I just remember as a RAC, the leadership was fantastic. They said, look, not every question is going to be answered right now. There are going to be things that come up that we have to deal with that we don't know today. But we're willing to take that step because guess what? Tomorrow we're going to be better than we were today. And the next day we're going to be better than that day. And I was just looking at the calendar before this webinar. We're in November. And I remember it was right at a year ago that we started and basically said, yep, we're going to go forward with this. So it's fun to see how far we've come in that year. And we'll get into more of that. So I think going back to that a little bit, Jennifer, when we look at, I think a lot of people get overwhelmed with that change. And so you talked about the crawl, walk, run. Expand on that just a little bit on what that methodology was to go, look, we're not going to try to, bite off the entire cookie in one bite. So how are we going to pragmatically go about this to where we can drip a little bit of technology and expand that over time?
So one of our biggest projects was EMS buy-in. And so getting EMS to use technology, use an iPhone or an iPad to communicate this report. And so we said, start first with your non-emergent patients that you're bringing into the hospitals, to the ERs. Start with those easier ones that you don't have to, move so fast with, and get comfortable with that and create the muscle memory with that. And then we started, okay, now move more with your complex patients, your more emergent patients. And so we took time with EMS and told them it's okay if you're not 100%, going forward with all of your medics on day one. And so we just worked with them and communicated with them monthly. We communicated at our RAC meetings as we rounded to EMS stations, how is it going? We answered their questions. And so we really just took it slow with the medics. And then we started with the ERs, with all of the ERs, educating the nurses, educating the physicians on how to answer it, what it looks like, and just kind of going slow with that and being very patient on that. And also, we did not take away their backup method. We did not take away the radios. The radios are still there in the event that they ever need to use them. We did not take that away. And so I think that was comforting to them to know that the method they've been all familiar with for many years is not gone. It's still there in the event that they do need to use it.
Awesome. Yep, for sure. And I remember too, it was, look, if we don't put a deadline out there, a line in the sand, then people will, just not adopt. And so even though there was, look, here's your backup, and we are going to start with the non-criticals first, there is still a drop dead date. And the RAC really pushed that to where it wasn't a opt-in, opt-out. We voted as a RAC to do it. We're going to go forward together, but we're also going to help along the way. So I think you touched on something too, that this didn't just start out as a trauma initiative. I think that's collateral, what we're looking at and what we're highlighting in this particular webinar. But we are going forward as a RAC because this is not just for trauma. This is all patient types. And we're going to solve the system of care problem in general. So, how does the solution fit into the big picture on all systems of care there?
So a lot of trauma programs, and I'm sure there's a lot on this call, are familiar with the halo effect of trauma programs. And we said, trauma, we will be the guinea pig. We will go first. We will figure it out. We will hardwire it. And then we'll add the other service lines after that, such as your STEMI, your stroke, your sepsis. And we'll work towards that. So the system of care is improved with communication, with time. And so we really worked on that to show the halo effect of this project. and that it will help improve patient care. And that's another thing when you're talking with, your administration and your IT and your HR departments about an app that's on phones, about the software, is talking to them and making sure that, the biggest purpose of this is this will improve patient care. This will improve patient outcomes, and just keeping that as a number one. And that helps to get buy-in and support on this.
Yeah, Randy, you mentioned the 12 leads as a precipitating factor for going forward with this, because people didn't have a solid plan to send in 12 leads. Well, that has nothing to do with trauma. And it may actually have nothing to do with STEMI. There's a lot of reasons that we provide 12 leads to hospitals, electrolyte imbalances or tachydysrhythmias and things like that. So being able to send better, more secure information forward prior to that patient arriving is really important, not just for trauma, but for a lot of different patient types.
Yeah, absolutely. The EKG or the 12 lead was definitely a driving force. But I tell you what, there's nothing that gets a trauma room ready quicker than a good picture of the incident. Your patient may sound pretty good, but here's a picture of their car and what we drug them out of. So picture's worth 1,000 words, and it definitely gets things moving very quickly.
Yeah, I was actually surprised the first week that we went live with comprehensive trauma there at Shoreline, and just kind of sitting in the ER for the week, making sure everything was going smoothly, and watching some of those pictures come across from EMS. I remember there was an ejection out of a boat there in the bay, and the boat came around and ran the individual over. And so the medics sent pictures of eviscerated, organs and a lot of different stuff, soft tissue injuries that now that trauma team can definitely see what they need to prepare for, and perhaps even chat with that medic that's in the back of the truck on some treatment that they might consider, because they're still 20 minutes away. So it really moves that care way up in that cycle.
Well, from your side too, because a lot of times when we get there, things are already wrapped up. They've already stopped bleeding. They've already done their bandaging. And so now I'm left to describe to the hospital what's under that bandage, but I'm getting it as secondhand information. So if they can take a shot of that and include it into our channel, then I get to give a good, not only verbal, but then they get a visual look at it at the same time. So again, picture's worth 1,000 words. It's a great function of Pulsara.
So Jennifer, walk us through what a typical trauma activation was prior to Pulsara. What was your normal process?
So the radio report would be called to the ER, or maybe a walk-in. Patient would walk in and they would activate the trauma team via pagers. Old school pagers were used, and what came across to the team that was carrying the pagers was just basically a bunch of numbers, meaning if it was a 911, if it was a level 1 activation, or a 922 if it was a level 2 activation, and that's it. They didn't get an information on what room the patient was going to, what the ETA was, any information about the patient. And so this was the next step forward that we took with Pulsara, is not only receiving the reports from EMS, but then turn around and taking that information, that exact report we received, hitting activate, choosing your trauma activation level, and then it would go to the trauma team with all of that information.
Yeah, so I think, when you look at what it looks like now, and I remember you were talking about the antiquated technology, and this was fascinating to me when we went live and I was in the ER and we had our first trauma activation. Of course, we're running dual process, so the ED clerk called the PBX operator, they sent out the pages, and then the Pulsara alert was sent at the exact same time. And the trauma team and trauma surgeons were actually in the room with the patient doing their assessment. And I want to say it was like 5 minutes later or something that Dr. Adamski's pager actually went off, and he looked at it. Oh, I'm being told there's a trauma activation, when he's already got his hands in the patient. So those delays are definitely sometimes quite significant. So as you describe now, basically what happens is when that alert is sent, the ED starts to look at the information that was presented. And, sometimes they are looking for that nugget that can tell them, I need to move this patient to a level 1 activation or versus a level 2. And so they're consuming things like vital signs or pictures of injuries and they can put that patient into that bucket. So they select level 1 or level 2. They press this big orange activate button, and then there's a pre-assembled team of individuals that are on call to receive those alerts in those situations. And these are just a few of these on the screen, but of course, your blood bank, your anesthesiologist, pharmacy, trauma surgeons, all in a group. And one thing that you can see in the screen is that I can see that 3 of my 3 people that are in my trauma team have actually seen this. And you can even dive in even further and look at specific individuals, and there's logs around this. So I think the accountability is certainly something that you see with this. The cool thing is once these individuals are brought in, so I'm a trauma surgeon and I was brought into this channel, you can see there are 2 images for this patient. They can look at those and start to consume a lot of the information. This also can go to registration at the same time, so these patients can get pre-registered and just start that process even faster.
And one thing that also a lot of ERs, a lot of hospitals do overhead paging. And so this has been able to take that away, the overhead paging, which is distractive to, patients and families that are trying to heal. Also, it's, overhead paging sometimes brings the looky-loos down to the department because they want to see what's going on when they've just heard, 5 traumas paged in the last 30 minutes. And so this software has helped to fix that issue too. So I was going to say, so just like I talked earlier about the crawl, walk, run, is we did that not only with the pre-hospital, we did it with the hospital on this activation process. And so we started first with our trauma program team and our trauma surgeons. We got everybody access. We kept the pagers. So we let them have their pagers still. And as we, so we have a duplicate process on this just to, until they're comfortable with it. But we start with the trauma surgeons first on receiving this and getting comfortable with that. And then we would start next with adding in, we added in pharmacy, we added in security. And so we basically kind of took it 2 weeks at a time where we added in a new group of people. We got them access. We did education and training with them. And we've just kind of continued to go each department that responds to a trauma activation to add them in. And then we know that there's turnover in some departments. We have to go back and do more continuing education with them. But one of the other things we did is, so there are some departments, such as maybe the OR board runner or maybe PBX, that doesn't need a handheld device. Then so we got them set up on a web browser, and so that they can receive these activations, these notifications on the web browser, and because that's all they needed, and they didn't need a handheld device. And so that helped on some of the departments that maybe did not have hospital issued handheld devices to be able to use that option as the web browser to receive these notifications.
Yeah, that's a great point. That you don't have to have a mobile device. I think a lot of the people that utilize Pulsara are mobile, and so that opportunity is a huge advantage. I'm on call, but I'm off site, and so now I've got this mobile device. But if I'm in a seat and I've got computers in front of me, and that is what I do all day, registration being one of those things, an ED clerk, PBX operators, then I do have another opportunity, and that's to use the browser, and it alerts me and everything just like a mobile device. So that flexibility is definitely good. One of the things I noticed too with Jennifer, just going to give her some accolades real quick, but staying on this process from an executive sponsor standpoint is so important. That leadership is, I could not implement this without that type of leadership. And for her staying on those groups and saying, hey, PBX group, this is Corey. He is going to set you up. I'm going to follow along and make sure that you don't need anything else. And then along the way, if we notice that there's hiccups, going back and readdressing that with re-education or perhaps a different type of device, whether they were on mobile and they don't need that, they need to be on the web. It's all of those types of things. But instead of just saying, okay, Corey, go implement this and I'm out of here, it was really, I'm right there with you and I'm going to help this process from an executive sponsor standpoint. That's a huge key to success. So one of the things that we realize, it's obviously great if somebody comes straight to your trauma center, but it turns out that people will go to the nearest facility and maybe something that can't take care of them. Or for stabilization purposes, EMS says, we got to have an airway. We've got to go to the first facility first instead of to the trauma center. So all of those situations happen. And so talk to me a little bit about how this improves moving from one facility to another facility and how we inserted Pulsara into that mix as well.
So if EMS utilized Pulsara for the patient that they took maybe to one of our level 4 trauma centers, the ER would receive that. If they, identified the patient had injuries that need to be transferred to a higher level of care, we then would use our CRISIS command center, our transfer center. And so bring them in the loop on this, and they would get the Pulsara. They would be added into the channel on that. And then we would reach out to the level 2 trauma center and communicate them that there's a patient that needs to be, transferred to them. And the trauma surgeon on call would receive it, as well as the ER physician, this information on it. And then when the EMS pick the patient up, whether it's air or ground, from the level 4 facility, they could be added to the channel 2. And so whenever they were transferring the patient to the level 2 trauma center and they were, sending in their report, the receiving hospital, the level 2 trauma center, could see all of this information from the time of the mechanism of injury through the ER at the level 4, through the transport, any changes in status, any pictures, and so it was a really good information. It wasn't a lot, but it was the key information that needed to be seen and communicated to help ensure we had, exceptional patient care. Randy, do you have anything, as you've been involved in that? Anything you want to add on that?
So I haven't experienced from the facilities yet, but what I have experienced is from the EMSs themselves. And I think I touched a little bit on that. And it's kind of just that same continuity of care that they, how, I don't know if you know how air crews are, but we have a very small amount of time we're supposed to spend in the back of that ambulance. And it is quick, down and dirty info. And there are going to be things you forget to ask or whatever. So Pulsara allows the chance for them to put that information in there, while before all that happens, and even add it after we've left. That's the great part. So I'm looking forward to seeing the other side of this as we go forward. And like Corey said, we're a year into this, and look how much we've done already. So in the coming year, I'm sure that we'll see a lot more of this on my side.
I think if we look at that crawl, walk, run phase, I think it would be safe to say we're sort of in a slow jog right now. So we have added the transfer center into the mix. So just to be clear, if EMS started a channel and they took it to a primary hospital, that channel already exists, and now that the primary center just simply adds the transfer center into the channel with them, and that really alleviates kind of that first 15 questions on a phone call, which is, where are you calling me from? What is your name? What is the patient's name? Could you please repeat that? What's the injury that this patient has? All that information is in Pulsara already, so it speeds that process up. I think when we get into that run phase, what we're going to see, and I'll talk to you a couple of ways that this can happen, but that sending facility then adds in the transport resource into the same channel. That way, we've got some really high-powered resources on the other end at these trauma centers that are waiting to receive that patient, and they're not real sure if they're going to get here in 15 minutes or 1.5 hours. It's sort of this dead zone or this black hole. And so by adding those transport resources into that channel, they can say, hey, we're with the patient. And Randy can say, you know what, they're decompensating. We're going to take a moment, go ahead and intubate. So now when they get there, they're actually going to be intubated. That was information we didn't have before. And these things change on a dime a lot of times with these critical trauma patients. So Randy, getting into that, this is a recent case that you were on. We've got some screenshots, so maybe it looks familiar, but this was that 73-year-old patient that had the tire that blew up in their face, and you were on this flight. And it's not the most critical of trauma patients, but I think it does a good job of illustrating what happens with that continuous communication and that handoff process. So walk us through a little bit of what this particular case was.
So the interesting thing about this is this was one of the first, maybe the third or fourth time that EMS had started to bring us into the channel first. We had put out instructions through CBRAC on how to do that, and we're starting to see more and more of this. In fact, I had one last night myself where they included us in the channel right away. So this one, the great thing about this one was their radios were not working in the truck that they were in. So without Pulsara, we would have had almost no information going in. And air crews, we're spoiled. We like to know what we're going into. Actually, we need to know what bags do we need to take in? Do we need to take our blood in? Do we need to, all these things? And so I was able to chat basically back and forth with the medic on scene, asking him all these questions, and he was giving a report, and I was asking questions back and forth. So this was a great example, and we even stated that either during the flight back or afterwards with my partner, saying, "Wow, look what Pulsara did for us on this flight. We would have gone into this not knowing anything that was going on, and we were able to actually communicate back and forth, even from 2,000 feet up in the air. So it worked really well."
Yeah, so you've got this ground crew that basically puts in a quick Pulsara report, puts in some information. They probably took some pictures that I can't show because of HIPAA as well, but and then they basically add you into the channel as you launch because they know what ship is coming to their location. And so we can see here that they've put in some of that information. And then as we scroll through here, Randy's actually talking to them going, "Hey, how's our airway look? Is there anything I need to grab out of my bag to deal with an airway?" They're saying, "No, GCS is 15, airway looks good." You're still 10 minutes out and you're telling them what your ETA is while you're in flight. So that's excellent. And then in the next part of this, you're actually sending the report to the hospital, and there's a patient flow coordinator at Shoreline that kind of is a paramedic position. They take a lot of the initial communications and they may assign room numbers or get patients in the particular trauma categories they need to be in. So they're even asking you questions while you're in flight as well, I see.
And I was able to add some more to the a different page that in the chief complaint, and added some things that I wanted the trauma center to know. Having worked in ERs before, I know exactly what it takes to get a level 1 activation versus a level 2 activation. So I know the lingo and the vital signs that they're looking for. So I wanted to make sure that they had all the information to make a good choice on who to bring into their channel.
Awesome. And so we mentioned that there is a way to add the flight crew in immediately, even before they've gotten to their location. But we also are spoiled in Texas. I want to talk very quickly about, we have a statewide wristband, and I would really encourage any state, whether you're using Pulsara or not, a statewide wristband has huge implications and merit from a continuity of care and a patient tracking standpoint. We actually baked in technology in Pulsara where we can scan that wristband. And this is kind of an example of what it looks like. EMS simply puts that band on a patient. But really what this allows from an interoperability standpoint is that a patient can be banded on initial patient contact, wherever that takes place, whether that's the tertiary or the primary care facility, whether that's in the field by a first responder. But that band gets put on a patient, and then we scan that band in Pulsara. And if that ground crew had scanned the band and Randy had flown in and now goes to that patient side, it's as simple as just scanning that same band in Pulsara and now being added into the channel. So along the way, anybody that comes in contact with that patient and has a responsibility for the care of that patient can scan that band, no matter what organization they're from, and they're added in, and they can collaborate and communicate with all of the folks that are in that channel. We had an interesting situation in Corpus, actually, where even the freestanding emergency departments use Pulsara. And they put a band on a patient because they needed to transfer a patient out. It was not a trauma patient, but they scanned the band, and even the sending hospital takes a picture of a chest x-ray, takes a picture of lab values, puts in a working diagnosis. And then that patient ended up leaving POV AMA and showed up at a different location, and that hospital was able to scan that band, and they were added into that same channel with the sending hospital. So pretty cool stuff. This is kind of our hurricane evacuation plan too. We'll get into in just a second, but that statewide wristband, for anybody that's on this and wants more information on how to deploy one of those, huge upside for this. I would say from both of you, Randy or Jennifer, since implementing this, and I know that we're not completely in that run phase yet, we're a year into this, but what are some of the biggest benefits that you've been able to see? And have there been anything that you really didn't even think that would be a benefit that you've recognized that it would be?
Benefits, I mean, really, it's communication, good communication to all of the team that's caring for the patient. It's very helpful when the trauma team is responding to the patient that they know more about the patient. They know the vital signs, they know the injuries. They're already starting to think their plan of care for that. And so that's probably the win is improved communication, which in turn makes improved patient care. Unforeseen benefits is, for a trauma program perspective, our ability to turn around and use the reports and the audit tools in Pulsara for accountability, for us to go in and look and see exact times that the activation, the times for EMS, the times that it was activated, that the trauma surgeon received it. And so for us, for a performance improvement perspective of a trauma program, to be able to all the behind the scenes tools that we can have to help us with a performance improvement of a trauma program. Also, sometimes it's hard for a trauma program is we don't know who was the ground EMS that called the flight service. And we know the flight service that brought the patient to him, but we don't know who that ground service was. And so we can use Pulsara and we can look in the report and we can see, oh, okay, this was Allegiance EMS that, was the first on scene. And then they, brought in Halo Flight to transport the patient to the hospital. And so getting more information that we need for our trauma programs, our trauma registry, has been a value and an unforeseen benefit of this.
Randy, I'm going to pick on you again. Actually, this was a really good move on your part. You were one of the first to adopt this in the Coastal Bend, even though you didn't have a hospital in the Coastal Bend to actually take a patient to yet, because we had just pulled the trigger and everybody decided this is the way that we're going to move. But as you mentioned, you guys have ships and transport far beyond the Coastal Bend rack. So tell me a little bit about how you're able to utilize this, not just in your little home area, but in other areas that you serve.
Yeah, so when I heard about Pulsara, this was my answer to going to other cities because we don't always transport into Corpus Christi because our service area is so big. Sometimes we end up in San Antonio, sometimes we end up in Laredo, sometimes we end up in the Rio Grande Valley. And so San Antonio for me was a real problem. Satellite phones are 50-50. They're hit and miss. Sometimes you get them, sometimes you don't. Sometimes they can't hear you. They say, sounds like you're in a helicopter. I can't hear you. Yes, I'm in a helicopter. So San Antonio was if CBRAC, if we had never gone with it here in this region, I would still be using Pulsara because if nothing else, it helped me in those other areas where we were transporting to that I had no radio communication with them and I had to rely on the satellite phone, which I'm just not a fan of from experience. So for me, yeah, communication and going into all those other areas. And yeah, we were number one to try this out, and I wanted to be that brag on Halo Flight. We always like to be kind of the trendsetter for whatever, and so we were glad to take that on. We're a small organization, and so it was really easy to implement, and we hoped that people would follow.
Yeah, and I would just say that your flight services typically have a lot of respect from your ground services and the hospitals and others in the healthcare continuum. And so for you guys to get on quickly really showed a positive example to others that, look, we think this is a good thing. We are endorsing this. We're leaning in and we're going full speed ahead. So I think for those ground crews, they looked at that and said, hey, Halo Flight's doing it. We should definitely get on board. And so that was just a really good example too.
I made sure to tout all of our experiences and successes going with Pulsara while they were thinking about, hey, do we want to do this? I'm like, hey, let me tell you about this story and this story on how it improved patient care. And so, yeah, it was a good thing. It was great.
So with that said, we've talked about that this isn't just a stroke thing or a trauma thing. It's not just a stroke. It's not just a STEMI solution. This is a systems of care solution in general. And unfortunately, we have things like hurricanes. We have mass shootings. We have people that are migrant populations that are coming through our borders that then jump out of an 18-wheeler, 100 miles in because it's 120 degrees in the back of that 18-wheeler. So we have these mass casualty events. So, Jennifer, talk to me a little bit about what your vision is for Pulsara and some of those large events as well.
So for large events, we have trained within our whole Christus Response system to use the Texas EMS wristbands, the teal wristbands, that they will be on all patients, and that there will be designated people within all the facilities that are able to go around and scan these patients' wristbands. And you can even take their picture if you need, or take a picture of their valuables. And in the event of an MCI event, in the event of an evacuation, such as a hurricane or any type of disaster, here in Corpus Christi, we definitely have a lot of risk, and so we have the refineries, we have the port, not only to worry about as well as hurricanes. So, but we have a way that we can track our patients, and this is something that we learned from Hurricane Harvey, is that we evacuated our patients out of the system. We evacuated them north or to safer areas, but it was hard to keep track of where they went, and especially if somebody reached out to us and said, where is my family member, to communicate exactly they are in room 403B at University Hospital in San Antonio. So with this method, we can use Pulsara to track our patients, to transfer our patients, and to keep track of them for communication and continuity of care.
Yeah, I think the important building block there is that because these people use it every single day, it becomes a ubiquitous part of their life. And so when they think emergency communications, it's Pulsara. And no matter whether it's the toe pain that's going to go to triage or it's the mass shooting where we've got 30 patients and we're distributing that load, we're actually doing the exact same thing. And we've made that really natural for ourselves so that this feels natural in our hand and it's what we're using. We did kind of expand the solution recently and have participated in some large scale events. And this solution does have a mass casualty or an incident command type structure to it as well that can scale up and allow an incident commander and others that are managing these events to, at a macro level, see how many patients are being tied to this particular incident and where they're going. So that at any given time, they've got kind of their finger on that pulse, if you will. And so kind of to wrap this up, we're in that jog phase. What does the run phase look like? What do you see are some other opportunities to expand this, not in trauma, but maybe in other parts of the system?
It's outside of trauma, definitely we want to get this hardwired for all patients that are being transferred maybe to a higher level of care, or patients that come in via EMS and we need to activate, such as a STEMI, a stroke, a sepsis, and even for mental health. We know that there's a crisis with mental health. How can we take care of this population and better communicate on them, and especially communicating information on that population?
Yeah, I know your police department had reached out to us recently to say, man, could we have Pulsara so that when we have one of these mental health or substance abuse patients, we could contact mental health facilities through this and help alternatively navigate those folks, because so many of those patients end up in the ER and are there for 24, 48 hours and are sitting on your wall and because they can't get in somewhere. So it's a great point. And then I think in final here, what's the tidbit of advice that you could tell another region or health system, like, here's how to do this right and get the most out of this, and how should you implement this thing the right way?
I would say take your baby steps. Don't wait to have the perfect process in place. Know that you're just going to start small. You're going to have, opportunities for improvement that you identify, but you just keep moving forward, and you don't wait to have, I need to have this whole process figured out from start to finish. Just take it in steps. And as you figure out this step, then you're kind of working towards the next step. And when we broke it down into pieces like this made it easier to move in, get going faster, and it made it easier project to deal with. Also, communication to your IT, to your HR, to your administration, and just communication up front of the wins of this, especially when you talk about patient safety, communication, continuity of care. And then of course the HIPAA compliance of this. There was some concerns because, this is on iPhones and iPads. And, with the security of that. And so assuring them then that you can run audit trails and that this really is a secure device. And so just really giving that information up front will help to get buy-in from your other departments that are needed for this.
Awesome. And so we have a couple of questions from the audience. And also, I don't know if our moderator is on, but we have, I think Dr. John Adamski is actually joined to this webinar. We might want to be able to unmute him to say hi, if it's possible, if you see him in the attendee list. As you're kind of finding him, let me address a couple of these questions. So number one, does Pulsara integrate with EPCR software? Absolutely. We have a public API. We are completely agnostic, and we will give our data to whoever needs to consume it. So with that public API, we have several EPCR systems already that have consumed that and have working interfaces. And then a couple of others that are actually in the coding process right now. We always hear from EMS, we don't want to double document. And I can tell you after teaching this, I really show that there's not a lot of manual data entry, if any at all, with this system. It's scan wristband, scan driver's license, take a picture, even of things like vital signs on your cardiac monitor screen. Then you're not having to manually type this stuff in. Talk to text on a chief complaint really mimics a radio report. So there's nothing manually that I'm having to document. But yes, it would be nice at the end of that if I can press an import button and now those demographics and my at patient time, certain things like that flow into that EPCR. Does it replace the radio report? I think, initially we kind of did a little dual process, but that quickly ended. We don't want people having to do double the work. So this gives a lot of information quickly and things that you can't give over a radio, like a patient's name or a picture of injuries or 12 leads. So we're really sending a bolus of information with a lot better info for the ER in which to make decisions off of. And there's no need then to send a radio report. And in fact, as soon as the hospital actually clicks into a channel and sees the report, it automatically sends a message back to EMS saying that the hospital acknowledges, and now there's a handshake so that they know it's been received on the other end. So can you access patient information later, and how long is this stored? So we are hosted through the Amazon cloud, and in the United States, that information is not purged. Of course, we have different rules across the pond that we live underneath as well, but for the United States, we don't purge the data. If I'm an administrator, I can go in retrospectively and run some of that data that Jennifer was talking about. And I'm sure Randy looks at these cases after they've been completed for QA/QI purposes. It's one of the requirements of things like CAMES to be able to do that 100% review. So seeing all of that information and being able to retrospectively look at it and dissect who did what when, and if there's been any delays or hiccups, they can put their finger on that. So I know there may have been some other questions in the chat. If we don't get to those in this live webinar, because I know we're kind of running out of time, we'll definitely answer those for you, and that way you've got the appropriate answers. So they did want to know, Jennifer, from you and Randy, what are some of the challenges that you ran into? And I think one of the things that you might touch on here is that trauma surgeon call, on-call thing. I think that might be good to talk about.
Oh, yes. Yes. So one of the things with Pulsara is you're logged into the app, but you log yourself on and off call. And so we noticed that, we got our trauma surgeon set up, but when we would go back for our auditing and look, they didn't receive the activation. And I was like, well, they're on call. Well, they forgot to log themselves on call. And so, we'd remind them, hey, you're on call. Remember to log yourself on. Remember, log yourself off, because they definitely don't want to receive an activation when they're asleep. And, they should be off call. And so we worked with Pulsara and where we upload the trauma surgeon call schedule monthly. We do a month at a time, and they do 12-hour shifts. And so we upload it into a calendar, and it automatically logs them off and on call. It's been amazing. That's probably been one of the huge wins of this, is that it automatically logs them off and on call, so we don't have to worry about that. And so they have been very pleased with that process change.
For us, the change to Pulsara, believe it or not, has been really seamless. It has not had many challenges for us. It's really just learning the system and utilizing it. There are some times that still our hands are too busy to get on our phones and even in the air, and sometimes we do end up using the radio. I would say same thing with Jennifer though. My crew has to remember to log themselves in every morning, but we just make it part of our pre-flight duties.
Yeah, the cool thing about that, Randy, is that even if your hands are tied, like last night, you had a 5-minute flight, so you're up and down, and there's a lot of operational things that we worry about for safety reasons in the air. It's not just patient care. But the cool thing is that ground unit started that channel. They can actually send right to that hospital on your behalf and say, look, Halo Flight may call you, but here's what they've got. And because we're the ones that originally started care. And if you're in flight, they find patient medications or want to take other pictures of things like mechanism, they can just keep adding that stuff to the channel so that when you land, the hospital has it, you have it, and that continuity of care is not lost. So I know we're down to 1 minute here. I have one more question I wanted to address, and that's on regional competition. And so one of the things I can say that I've been really proud of in Texas is that we are broken down into these racks, and each of these racks has multiple health systems that are in competition with each other every single day. But what I find is that these racks do breed cohesion in a lot of ways. And so even though we know that we're competitors, we're still moving forward at a macro level as a region for the betterment of that patient. And so you still have your proprietary processes. We're not giving away any of that. But because we've standardized a way to communicate, everybody benefits. Because at some point, the MCI is going to happen where we all have to share the load. At some point, we're going to need to evacuate that hospital because the hurricane comes in. At some point, X, Y, or Z happens, and we have to be on the same page and collaborate. And so if we're siloed, that breaks down. And COVID really brought that to light. And that's the reason that we got this state contract in Texas, so that we could standardize how we move patients and how we talk to each other across the state.